Hi, we're going to go ahead and get started if you want to have a seat. My name is Julia Wall. I am the DBS Program Coordinator at Henry Ford Hospital. And I would like to just mention if I have programs here if anybody is interested. And if you need any professional credits, it's a blue form to be filled out and turned in by the end of, upon exiting. Today we're lucky to have Dr. Jason Schwab, who obtained his MD from Yale University. He was named a FAR Scholar, one of five recipients of the medical school's highest thesis award. He completed his neurosurgical residency at the University of Pennsylvania with an infolded fellowship in spine surgery. He then completed a fellowship in stereotactic and functional neurosurgery with Andre Lozano at the University of Toronto, during which time he obtained additional training in epilepsy and peripheral nerve surgery. He is currently the surgical director of the Movement Disorder and Comprehensive Epilepsy Center and research scientist in the Center for Health Policy and Health Services, Henry Ford Health System. He serves on the Professional Advisory Board of the Michigan Parkinson's Foundation and is the current co-chair of the Functional Neurosurgery Working Group of the Parkinson Study Group and Secretary-Treasurer of the AANS-CNS Joint Section of Pain. Dr. Schwab?
So I want to be sensitive to everyone's time. So the way we're going to try and do this is I'll do about a half-hour presentation to try and answer some of the frequently asked questions. And then Kelvin and I will do a Q&A for any questions you guys might have about DBS, although I see there are a number of people here with the appropriate scars who already have systems. So just in terms of my disclosures, I am going to talk about placement of DBS devices without awake intraoperative testing. That is not the way DBS is labeled by the FDA, so it's off-label. And I was an investigator for St. Jude's pivotal trial for their device for essential tremor and Parkinson's disease. So, just as a bit of background, and many of you already know this, and people who went to John Goudreau's talk probably know a fair amount of this as well. There are a lot of pharmacologic options for patients with Parkinson's disease. The sort of mainstay, the workhorse, is Levodopa, Carbidopa, traditional Sinemet that's been around since 1967. It now comes in newer formulations which may be better tolerated, like Rytari or Duopa, but it's basically the same thing. And then there are other classes of drugs like dopaminergic agonists like Mirapex and Requip, and then other medications that act on the pathway of the conversion of dopa to dopamine, or decrease the breakdown of dopamine after it's been formed, like selegiline or rasagiline. And then there are other medications that can be helpful for patients with movement disorders, like anticholinergics like Artane or Cogentin, and this medication amantadine, which is actually originally used for treatment of flu, can actually, under the trade name Symmetrel, can be helpful for some patients once they develop levodopa-induced dyskinesias. And then, of course, there's non-pharmacologic treatment, no treatments without medication, so some of the physical therapy, exercising, and LSVT big, and acupuncture and things that can be very effective. So Sinemet, there was initially a concern that taking Sinemet would speed up the course of the disease. That's been pretty well disproven at that by now, and it really works very well for the cardinal symptoms of Parkinson's disease. So it helps with slowness, it helps with rigidity, it often helps with tremor, but sometimes it doesn't. Sometimes it's not very effective unless it's in very high doses. But it does have side effects. It can cause GI upset, can cause, and over time, even though almost everyone gets really good benefit initially, if they do truly have idiopathic Parkinson's disease and not one of these weird Parkinson's plus syndromes, over time patients can get motor fluctuations where the drug doesn't kick in predictably and they're frozen, or it wears off unpredictably and they're frozen, and it can cause low blood pressure. It can also cause cognitive changes as well, and with some of the medications like Mirapex, it can cause hallucinations. So even though most patients do very well with medications, at least initially, and there are patients who do very well with medications for 10, 20 years, don't get me wrong, but a significant percentage of patients after several years of treatment can develop extra movements, so dyskinesias, and motor fluctuations. And this is what you see, when you see Michael J. Fox, where he doesn't want to be frozen, so he takes an extra dose before the interview, and he's sort of writhing all over the place. Although when you see him acting in something, they usually can time it pretty well, so he looks pretty good and doesn't have the shakes. Many of you may have heard the talk at one about freezing of gait. But patients can also get fluctuations in terms of their mood, in terms of their thinking. And what happens in general is a lot of patients, they get this they're on this roller coaster where the medication either is working really well or it's not, or they're getting extra movements. And so when I'm talking to a patient in the office, we often ask the patients either to tell us or to fill out a diary, how much of the day are you frozen where you don't feel like you have enough Sinemet? How much of the day are you on where you're good? And how much of the day are you on but have extra movements that you find bothersome? And younger patients are actually more likely than older patients to develop these motor complications. And this can be, we're not really sure exactly what this is due to. It's partially due to the pharmacokinetics of the medication and the changes in gut absorption, but it may also be, just also due to progression of the disease. And there are a lot of ways to adjust that. And one of the questions I ask patients when they come in, especially if they're not being seen by the most experienced movement disorder neurologist, is, how come you're not taking more Sinemet, or at least more frequently? So instead of taking it 2 or 3 times a day, you can break it up into smaller doses. And frankly, most of the patients we're operating on are at the point that they're taking Sinemet every 3 hours. And then there's the other approach would be to add on other medications or switch the medications around. There's some controversy about amantadine. It usually will help and buy you some time, maybe 3 months, 6 months, but usually a year later they're back in your office and it doesn't make a big difference. And so, for patients where they're getting this seesaw, or if they have tremor and the medications don't effectively treat the tremor and their tremor really bothers them, DBS can be very effective. And the reality is that, DBS is no longer new. Calvin and I have been involved with doing DBS since we were residents in Philly in 1998. Was when we started doing our first cases. And it was done, for several years before that in Europe before we started doing it in the US. But what is deep brain stimulation? It's basically like a pacemaker for the brain. It's open loop, so it's not detecting any abnormal signals in the brain. It is just delivering pulses all the time that you have the machine turned on. And it's very high frequency, so we're talking usually 110 to 180 hertz. So several pulses a second. And it can be turned on, turned off with this patient programmer. As you can see here, this is the one patients get, although the new one looks a little bit different. And this is the one, the physician programmer, that's a little more complex. And the idea is that you can change the parameters, you can adjust, you can steer the current to some degree, and you can turn it up and down. And so instead of the old days where we muck around with the circuitry in the brain by burning a hole or freezing an area, now you can turn it on, you can turn it off, and that way reduce the likelihood of side effects but still get significant benefit. Now that being said, there are patients where they have problems where you turn it off and the side effects don't go away, but we always try and turn it off. And for the most part, we can tweak the settings and make people better and reduce side effects. So this is the major one that's marketed in the US. It's actually the only one marketed in the US that's made by a company, Medtronic. And this is a mock-up where there are 2 electrodes, and you don't have to put in 2. You can put in 1 if it's appropriate. Wires going into the brain, and then extension cords going behind the ear, and then a pacemaker on the chest wall, just like for a cardiac pacemaker. So, over 100,000 of these have been placed worldwide since the mid-90s. We've had FDA approval for tremor since '97, and then for the other symptoms with the other 2 targets, there are 3 main targets we use in the US for patients with Parkinson's disease in 2002. Primary dystonia we've been doing in the US since 2003, and actually DBS for OCD, obsessive compulsive disorder, was FDA approved in 2009 under a humanitarian device exemption. St. Jude, actually, a competing company, does have FDA approval, although they're not marketing it at all. They were approved last June, and they're waiting for some new platform and some new changes to their system before they're going to be releasing it around the U.S. And, to some extent, DBS, at least to many of us in this room, is old news. It's sort of standard therapy for patients with PD, although it's obviously scary to many people to consider undergoing brain surgery. And there have been multiple prospective randomized trials where you take patients, you say, okay, we'll put half of them and give them either surgery, or half of them give them continued medication, and randomize them. And we have multiple trials showing that, not surprisingly, DBS is much more effective than continued ineffective medical therapy. So who's a good candidate for DBS? So in general, patients where we know they actually have Parkinson's disease, and we're much more sure of people having Parkinson's disease instead of some weird Parkinson's plus syndrome like multisystem atrophy or progressive supranuclear palsy. Once they're about 4 years out, we're much better. The neurologists are much better at saying the patient has Parkinson's disease. Patients who are younger tend to do better. I think mainly because the disease is slightly different, but it's also because they don't have a lot of the same neurocognitive problems that older onset PD can have. In general, we want to see that the patient does respond to levodopa. That's some confirmation that the patient actually has Parkinson's disease. And the patient has to have complications from the medication. When I see a patient and they're saying, well, I never get dyskinesias and never get any problems from my meds, but I'm frozen all the time, the answer is take more medication and take it more frequently, not put wires in people's heads. The patients who have a lot of instability on their feet, poor balance, tend not to do very well with DBS. Patients with severe dementia, it doesn't matter if you make their movement better, and there are some cognitive risks of DBS that you can actually hurt people. And we all have our patients where we've made their movements better but made them cognitively worse, and they're less independent, and it's not worth it. And then, if the patient is too ill or needs to be on blood thinners, then they're really not a good candidate for surgery in general. So what is optimal medical treatment? So we need to make sure the patient has enough dosing. And then I talked about this a little bit, that amantadine is a bit of a question mark. Is it worth doing that if they're going to end up in the same place in a few months? But in general, for me, I want to see that the patient's been on adequate dosing. And I think, I don't know what your feeling is. I think, with the new formulations like Rytari, I think we're doing a lot more. It's almost becoming standard of care to try Rytari, before pushing someone to DBS, because we have seen patients do so well on it. So who's not a good candidate for DBS? A person whose main problem is with balance, person who has a lot of problems with their thinking. And we do neuropsychological testing on all our patients, as does Kelvin in his shop. And people who are too sick or too frail that surgery is just going to hurt them, and people in whom the diagnosis is uncertain. So, we've known for some time, and I was involved in writing the systematic review in 2005, the data really hasn't changed over the past 10 years. We see significant improvement in patients from their off state with significant improvement in tremor, even if the tremor is not responsive to Sinemet, rigidity, slowness of movement, to some extent gait and postural symptoms, and then a huge benefit in terms of extra movements, the levodopa-induced dyskinesias. They basically go away. And what you end up seeing is a patient is they're acting like they're at their best on their medication all the time. Not really better than that, but usually pretty much at their best all the time. They don't get the fluctuations anymore. And again, this isn't anything new. We've got 5-year and 10-year data that show that that benefit is sustained. Patient still has Parkinson's disease. They'll still have worsening constipation. Their voice will still get softer over time. They may get some more instability on their feet. But the things that DBS helps with, like tremor, rigidity, slowness of movement, those are helped even at 10 years. And this is an old trial. This is now 10 years old from the New England Journal, and shows that we're not just making a difference in terms of rigidity or tremor, we're making a difference in people's quality of life in multiple domains. And I didn't show that with all the figures from the paper, but it really shows significant benefit overall. And patients in the surgical group go from 3 hours a day where they're doing well on their medications, they're able to move, they don't have a lot of extra movements, to 7 hours a day. And even in the hands of expert movement disorder neurologists in the medical group, they just continue to get worse because it's progressive disease. So you make a big difference. And in fact, these patients actually got a little more sleep too. And this is at 6 months, and this is borne out over time. So here you see, there's improvement in mobility in the surgical group, activities of daily living, emotional well-being, stigma, bodily discomfort, social support. There are actually some benefits in cognition in this paper and in communication. And this is really, where you see the most benefit. This is a patient I implanted almost 10 years ago, who was able to dance with his daughter at her wedding as opposed to being in a wheelchair, frozen in a chair, or not knowing if he tried to get up with her that he would freeze, whether or not he would freeze and have to sit down or have to be carried off the dance floor. Now, as I said, patients don't usually get better than their best scores when we do sort of formalized neurologic exam when they're on. So other than tremor and dyskinesias, we don't get patients better than they are at their best condition. The surgical procedures reduce tremor, and they reduce the time when they reduce those fluctuations and the increased movements associated with surgeries and medication. So I think one of the issues is getting the patient at the right time, because you don't want to do it too early. It may be that you just need to put the patient on more medication. They'll define they don't need an operation. You also don't want to do it too late where they have a lot of problems already with their balance, already with their thinking, where the risks are higher and it's really not worth it. And taking someone who can't move, who's in a wheelchair and putting electrodes in their brain, you're not going to get them out of that wheelchair and make a big difference in their quality of life. It's probably not worth it. So when is the right time? And so, there has been an effort, especially by European groups, to look at, what point is it appropriate to introduce. And there has been a trial going on for some time, led by the group at Vanderbilt in Nashville, trying to look at this as well. How early should we be doing it? Because we know the patients that we do earlier, they're still doing well. And if you get a patient who hasn't lost their job yet, who isn't disabled, they may be able to maintain their employment and maintain doing the things they want to do. So this study was, the early STIM study was published a couple of years ago, and that shows that, again, it seems to work better the sooner you do it. So still 4 years, greater than or equal to 4 years out from diagnosis or first symptoms, still responding to Sinemet, but probably a little, we should be considering DBS a little bit earlier. It's surgery, it's scary, but the reality is we've been doing this so long, the risks are quite low. We published this 10 years ago, it really hasn't changed. The risk of death on the table or around the time of surgery is less than 0.5%. The risk of bleeding in the brain causing a stroke, causing a neurologic deficit is less than 1%. There is a risk of psychiatric complications, but frankly, there's a risk of psychiatric complications from medication. And even in that large trial that was published in the New England Journal, one of the deaths was from medication-associated psychosis in the medical group, not in the surgical group. So it's not clear to me, maybe a bit of a wash there. So it's very precise to get this electrode into the right place. So the target is small. It's about 5 or 6 millimeters. The diameter of the electrode is 1.3 millimeters. You're going from the surface of the brain or surface of the skin, to a significant depth. So if you're off a couple of degrees, you miss. And frankly, if you're off more than 2 or 3 millimeters, it doesn't work. And we get postoperative imaging on all our patients to make sure the electrode is in the right place. And there are a number of different ways to make sure you get the electrode in the right place. First is imaging and selecting the target, and so we use MRI and CT. And then the traditional way of doing this is with verification that you're in the right place. And the way to do that is with an awake patient, where we go down with a very small electrode, much smaller than the 1.3 millimeters, and listen to the neurons as we go. And I know what a neuron in the target sounds like. I know what the neuron in the areas that aren't in the target sound like too. So I know I'm in the wrong place. And then we can send current through the electrode and see if the patient gets benefit or not, or gets side effects or that we don't like to see at very low thresholds that suggest we're in the wrong place. And then we can place the system, and then a lot of the work gets done in the office by the neurologist, tweaking the settings to maximize benefit and minimize side effects. You will get side effects if you turn the juice high enough, even if you have perfect placement. So just to give you an idea, this is a pretty small electrode from a large distance to get into this little target in the STN, subthalamic nucleus. This is an electrode going into the globus pallidus pars interna, or GPI. And there's a lot of controversy about which is the right target. There was a recent paper published within the past 3 months that Dr. Sideropoulos and I wrote commentaries about that have been in the literature. There's also the Veterans Administration trial. In general, what I say is, with all comers, we have a longer and better track record with STN DBS in terms of the improvement in the motor symptoms and the movements. However, more recent trials, it seems that the other target GPI is probably just as good in the 2 major trials. In one of the more recent, it wasn't quite as good, and I think that may be an issue with how they were doing it. There may be some higher cognitive risks with STN. So, what we do in our shop is for a young patient where there are no neuropsychological concerns and they don't have any postural instability, they're very stable on their feet, we tend to choose STN as a target. If we have any concern about balance or about the patient's thinking, we'll tend to go towards GPI. What do you guys do?
We do basically all STN. So,
Yeah.
you can look at the data in different ways, but sorry. It wasn't turned on. Look at that. So at the University of Michigan, we basically implant everyone using the STN target, the subthalamic nucleus target. You can look at the data many different ways. I think our general thought was we have a lot of experience putting the electrode in the subthalamic nucleus. We've gotten very good at it. And when you look at the data comparing the 2 targets, there's really not a whole lot of difference in motor effect. In this particular study, this is the VA study, the STN was slightly worse. So patients who were implanted with the subthalamic nucleus were slightly worse on one cognitive test out of all of the ones that they administered. They were slightly worse on a depression scale that was administered, and I'm not sure how much that is clinically significant. And so because we've gotten very adept at putting it in one target, we've just opted to continue to do that. But there are a lot of different ways to look at the different targets. So I'm not saying we're not right, but basically I think both targets are equally good and effective.
Yeah, I mean, it's hard to argue. There's a lot of data going either way, and frankly, the way we're doing things, we're only doing a single pass, and we know that the more passes, the higher the neurocognitive risk. So it's probably okay. I think it's probably my own personal bias as someone who is terrified of cognitive problems and of dementia, that I tend to shy away from anything that smells like cognitive risk. But that's probably my own bias, and use that when I'm talking to patients. And then there's another target called VIM, which is good for tremor only. It does not help with the other symptoms, but really has very low cognitive risk. So sometimes we use this in a patient with Parkinson's disease who has a lot of tremor, and that's really predominant, but we're concerned about cognitive risks of the other two targets. So the general way to do this is to put this box on a patient's head and get a CT, and then we have X, Y, and Z coordinates for every point in the patient's head, and we're able to program into the frame how to get to that target. And in general, the spatial accuracy of CT is better than MRI, so like many programs, we do MRI a week or 2 weeks before, really within 3 months of surgery, and then a CT with the frame on the day of surgery. And then we plan our trajectory to avoid blood vessels, to avoid the fluid-filled spaces of the brain called the ventricles, to reduce the risk of bleeding. And we can refer that to a standardized brain atlas or we can directly visualize the target sometimes on the MRI. And then here's the size of the electrode. Which I said is 1.3 millimeters in diameter, and a DBS microelectrode that we do the testing with is less than 50 microns, so really tiny. And we listen to the cells as we go down, and this is sort of the static you hear. And to me, I hear that this is about 40 to 60 hertz and slightly irregular, and if it responds to moving the patient's opposite arm, I know I'm in the right place for STN. And if I go 3 millimeters deeper, it's a little faster and it's pretty steady. And that's substantia nigra pars reticulata, and that runs at about 80 hertz. It probably sounds like static to you. To me, it's music. And after about 5 or 10 cases, our residents and fellows can't tell the difference, but they usually can't at the beginning. And then this is a tremor patient. And you can see on the left, we haven't quite found the target or the right settings. On the right there, we're dead on. You can see, really instantaneous benefit in the operating room, which is just incredibly gratifying. For the essential tremor patients, I'd say about 30% start crying. It's the first time they've been able to write their name in a decade. And even though this video is almost 10 years old, I still use it because I like the way she holds up her hand to look at it. So, it's a lot to go through awake surgery. As much as the neurosurgeons enjoy it, it's a really pretty amazing experience. And we do have patients, especially the patients who are engineers, like it because they get to hear their own neurons. It's very appealing from a scientific point of view, but most patients are pretty terrified. And to do the surgery in a patient with Parkinson's disease, we do it with the patient off their medications, so they can be quite uncomfortable. And so there's been a move around the U.S., even though it's not FDA approved, to see if we can get it in the right place by doing it asleep. And some people do this with intraoperative CT. That's been pioneered by the group out in Portland. And we've been doing intraoperative MRI, which was pioneered by the group at University of California, San Francisco. And our paper, we actually have the largest series outside of UCSF. It was published yesterday in Journal of Neurology. And our results are really, just as good. And this is nice because, we actually do the operation in the MRI, so we can, if the brain moves, if we let off spinal fluid or air gets into the head, we see it, and we're able to align everything before we pass the electrode down. And I think, that leads to decreased neurocognitive risks, and patients are a lot more comfortable. The incision's a little bit bigger, but that seems a reasonable price to pay. And our accuracy is superb. In the 12 patients, reported in this paper, and it's just as good afterwards. We have, about a 1 millimeter accuracy, or less for most of our GPI targets. So here are our 12 patients, and they run the gamut of 5 to 16 years of Parkinson's disease, ranging in age from 57 to 73, and they're all getting pretty significant benefit as reported in the literature. So it's not just the accuracy; it's also the same degree of clinical benefit, and we haven't seen any more cognitive effects than one would expect. So at our shop, we do 2 surgeries a couple weeks apart, mainly because of insurance reimbursement, frankly. So in general, the patient has their electrodes implanted. Almost all go home the next day. Sometimes with the intraoperative MRI, they stay an extra 2 days because they're just sort of pooped from the anesthetic, and patients with Parkinson's disease are very susceptible to the anesthetic. And then a week or 2 weeks later, under general anesthesia, we implant an extension cord to the pacemaker. That takes about an hour or less, and that's an outpatient procedure. Now, when we insert the electrodes in the brain, a lot of people, just from inserting the electrodes, have what's called an insertional effect. So they get significant benefit just from that. And so we usually wait for that to wear off before we do the programming. So you might not have your system programmed in the neurologist's office until you're about a month out from surgery. And it can take several times to figure out the right setting. So usually about 3 months before we get optimal settings, where you're coming in every 2 to 4 weeks to get things tweaked. So important, DBS is standard of care at this point, so all insurers, I don't know of a single insurer that doesn't approve DBS for Parkinson's disease. There really is no age cutoff. I worry more about cognitive effects greater than 70, but we've done patients up to 80. For patients with tremor, we will do patients over 80. I'm a little reluctant to do anyone over 80 with PD for STN or GPI as targets. Movement neurologist manages the device. Not everyone is as expert a programmer as Dr. Chu or Dr. Sideropoulos. There's a fair amount of literature of patients where they're sent back to surgical centers for saying, oh, this didn't work, and again, in someone's expert hands like Dr. Chu's, and they can make it work and not have to reposition electrodes or things like that. And more evidence seems to be coming out that we can do this as well with the patient asleep as we could with the patient awake. So I'm going to close with that and open things up for questions. You can direct it to one or both of us. For the healthcare providers in the room, I forgot to put this in my talk this morning, but we do have a large epilepsy symposium with a gala dinner at the Detroit Historical Society on May 13th and 14th at Henry Ford. Thanks.
Thank you, Dr. Schwab. And I would like the opportunity to introduce Dr. Calvin Chu. He's been very active with the Michigan Parkinson's Foundation's Professional Advisory Board since 2008. He is on faculty at the University of Michigan, where he is the Thomas H. and Susan C. Brown Early Career Professor and is Associate Professor of the Departments of Neurology and Neurosurgery. He is the co-director of the STIM, Surgical Therapies Improving Movement program at the University of Michigan Medical Center in Ann Arbor. So with that, we'll start questions.
So I'm wondering, you were talking about, they're going to have cognitive effects potentially with DBS. They're also going to have that with medication. So my question is are they the same types of effects, or do you see certain effects with one that and different with the other, or are they typically the same types of cognitive impairment?
So the most consistent change we see with DBS is depending on the target, is a drop in verbal fluency. So that's like, you have 1 minute, name as many animals, or name as many fruits that start with the letter A, that sort of thing. We're usually not seeing, so there are some slight differences. Do you want to address from your standpoint what you guys have seen?
When you look at formal neuropsychological testing, so that's all the tests that they make you do before and after. Really, the one thing that is consistent is this verbal fluency. So that's really naming as many words as you can, beginning with the letter F, or some people do animals or vegetables or things like that. It's really unclear how that actually comes into play in day-to-day life. So you can't name that many words in a minute. On a day-to-day basis, what does that really entail? And no one actually has been able to figure that out in the literature. Some things, it just depends on the person. Some people might feel like, we get comments like, my spouse is not quite the same. I can't put my finger on it, but there's something a little bit off. But then when you do all the tests, it looks like it's pretty stable from prior to surgery. So you asked whether or not medications makes it different. I don't think that medications is all that different. So my thought is that a lot of the cognitive problems that come from deep brain stimulation really occur many years down the road. And so in that case, I don't think you can actually really say it's due to deep brain stimulation. It's really probably just a progression of cognitive problems that you would have seen anyway if you did not have the surgery.
That being said, I agree with that, and I agree with the skepticism about the VA trial and about the two targets that, maybe it was just a random thing that showed up on one test. That being said, there was also some data from the VA trial. And there are patients, that we've all seen. They're rare, but it does happen where they take a significant cognitive hit, even without obvious bleeding in the brain. It's rare, I'd say probably under 1%, and they're better in terms of their movement, but their thinking it's that, the wife can't put their finger on it. We're not able to pick it up on neurocognitive testing, but it's real. And even in the VA trial, they showed that, patients who took a significant hit, their quality of life wasn't better, even though you made their movements better. So I'm always, and that's why we do the neurocognitive testing. We might want to make sure there's enough neurocognitive reserve, the patient could take a slight hit.
I have two DBSs. By the way, they've worked beautifully for the last 15 years. Do you have data on how many times they fail, in particular the electrodes?
Do you have data on how it fails? You can, if you want to address the hardware.
Yeah, so hardware-related issues are not uncommon. Usually it's an issue with the battery. Sometimes we get damage to an electrode when we're trying to change things, and that's why, if the patient already has two single-channel batteries, I'm reluctant to rewire everything, to a single battery, which may be more convenient, but I think there's risk of damaging the electrode. In patients who have dystonia, where they have a lot of neck movement, not surprisingly, they break wires. And that's been reported as high as 8% risk. So that can be pretty high. The batteries, to be honest, I haven't been that happy with how long they last the past couple of years. But that's something you can generally fix. We don't have that many broken wires.
I would like to know if the DBS affects the part of the brain where the anxiety symptom comes in.
So the question is whether or not deep brain stimulation affects anxiety, for better or for worse, I guess. There are two ways of looking at it. For anxiety in Parkinson's disease, many patients get anxiety when they wear off of their medication. So as the medication level is going down, They start feeling their heart rate, sweaty, jitteriness, some symptoms that would be consistent with anxiety. And then they take their medications and that type of symptom goes away. Again, deep brain stimulation makes the off time more like the on time. So we oftentimes will say that if you have anxiety and it's due to wearing off, a lot of times that actually gets better with deep brain stimulation because you're making the off time more like the on time. You don't have as much wearing off. Then there are patients who just have generalized anxiety. It doesn't correlate with medications, and they're anxious, and that typically doesn't get better with deep brain stimulation. It doesn't necessarily get worse either. So it just depends on what situation you get the anxiety in. I don't know if your experience is different.
No, I think that's pretty similar. If the anxiety, you have to look at how it's related to the dosing too. If some people get anxious when they're off, some people get anxious from when they're dyskinetic because they have so much dopamine in their system. So a patient like that might actually be a better candidate for STN DBS, where you can drop down the medications a lot more than you can with the other target with GPI. So we try and account for a lot of these things together, both with anxiety and depression when we're choosing target. And it takes some time. The expertise of people like Dr. Chu is not just in tweaking the stimulator and making sure the person is a good candidate for DBS. It's also making the adjustments to the medication so that the patient does well after surgery. We've all seen patients where they come down too fast on the medications after surgery, and the patient has acute depression or other problems. So it takes some expertise to tweak everything at the same time.
Is there any benefit for a patient who has their main symptom is on-off fluctuations, for the patient to be awake during the surgery, where there is not as an immediate feedback like with the tremor?
Yeah, so the FDA is still labeled that way. And when I was consenting patients before we got this data, a year ago or a year and a half ago, I would say, the gold standard is still awake surgery. At least our limited results in 20 or so patients show that we're doing just as well with a sleep surgery as awake. So my mentor said, if this works and we're no longer doing awake surgery and microelectrode recording, I'm going to go become an ice cream man or do something else than neurosurgery. It seems like the results are better, and there was there is some indication that when you're doing something like iMRI, I think we've had one case where we've had to do more than one pass with the electrode. The fewer there is good evidence that the fewer passes, the less cognitive risk there is to the patient.
I may.
If you're doing the awake surgery, are you more accurate if you have the immediate feedback with tremors?
Doesn't appear to be. So we are still doing, it is rare for me to do awake surgery in patients with Parkinson's now. And part of that is because of our referral patterns. People come to our center because they know we do it and we have a lot of expertise in it. But it's also, it's also hard to justify for us. We are still doing awake surgery for tremor, for the other target for VIM. And that's really based on comfort level. I don't know that it might be fine to do that asleep. It's a little harder to see that target discretely on the MRI to make sure I'm in that target. Whereas for STN GPI, I know what that target looks like. We've got 20 years experience. We know where the electrode's supposed to be and can directly visualize it. I think if we weren't sure or we really didn't know what the target was, then I'd want to do intraoperative testing. But at this point, I don't think so. And I think, any one of us who have a lot of experience in microelectrode recording, you do that track and it's not quite right. And the more tracks you do, you're getting more and more brain shift and you're chasing your own tail, and you're less likely to get it in the right place. To be honest, I'm a reluctant believer in a sleep DBS.
So my understanding of your question is that, are you wondering if you don't have tremor and you're off medications for your surgery, whether or not that can be tested in the operating room? At least that was kind of the way I understood your question. Is that true?
What I'm asking is if the main symptom is on and off,
Mm-hmm.
and you can't get immediate, you get the electrode in the right spot, and somebody has tremor, you can see that tremor go away.
Right.
Immediately.
Right.
But you can't actually normally see somebody go on that quickly.
Correct. So,
Right.
so there are some. So if you can't test tremor, so at the University of Michigan and actually, in other awake surgeries, when you're off medication, oftentimes you may have rigidity, stiffness, which the neurologist can examine, or bradykinesia, which is slowness of movement. And sometimes, and so when you put in the electrode and you test it in the surgery, meaning you turn it on and set it, you can actually get improvement in the rigidity. So the stiffness of the arms or the legs can go away with the stimulation turned on. Sometimes the bradykinesia, which is a slowness of movement, you can actually see improvements in that too. The rigidity tends to go away much more quickly. The tremor is the quickest thing to test. Rigidity or stiffness goes away fairly quickly too, and you can test that, just so you know. But if all of that is not testable, a lot of times what we do is we test for side effects, meaning you go up on the stimulation, and like Dr. Schwalb said, if you turn up and any amount of juice that you give, you can get side effects. What we're looking for is that you can turn it to a certain amount before you get side effects, so that you know that with fairly low voltages, people don't have too many problems with it. And that's the way it's been done for several years, or actually since it's been done.
Did you say that you're in an MRI of the operation?
Yes.
Isn't it noisy?
Uh,
I mean, when I've had an MRI, it's
Yeah, so
Clanging.
one of the things we always check is to make sure the earplugs are in place on the patient. And then, what the workflow is, we're doing our work and then we're taking intermittent MRIs. It's not like the MRI is running
okay.
the whole time. And when we're taking our intermittent MRIs, we're wearing earmuffs as well.
thanks.
Well, I think that's it. Thank you very much. Appreciate it.